Okay, we're going to go ahead and get started, and we want to give our sincerest apologies for the delay. We've had some technical issues this morning, but we're ready to go. First off, we want to thank everyone for participating in our project's first webinar, How Undernutrition and Hypertension Impact Preeclampsia and Eclampsia and Preterm Birth. We have presenters Tabassum Feroz from the Warren Alpert Medical School at Brown University and Yannicka Hartvig-Blomberg from the Global Alliance for Improved Nutrition. We were also planning to have Laura McGee from St. George's Hospital, London, but due to other technical difficulties, she will not be able to join today. So we are going to go ahead and get started. Our first presenter is Tabassum Feroz from the Warren Alpert Medical School of Brown University. Her clinical focus is medical complications of pregnancy. She is a member of the WHO Maternal Morbidity Working Group, the UN Commission for Life-Saving Commodities, and she co-chairs the joint ISOM-ISSHP Global Health Committee. Her research focus includes postpartum maternal health following preeclampsia and global maternal health policy.
Hi, everyone. So I will be speaking about preeclampsia as a risk factor for preterm birth, low birth weight, and neonatal mortality. So we'll go to the next slide, which has the objectives for my short presentation. So I will begin by first outlining the pathophysiology of preeclampsia and its natural history so that we can set the background for the talk. I will then talk about the epidemiology of perinatal morbidity and mortality as it relates to preeclampsia. And finally, as you will see at the end of the presentation, we will be able to identify the gaps and potential areas for research and action in this area. We'll move on to the next slide. When we look at the pathophysiology of preeclampsia, as you can see, it is very complicated. Preeclampsia, as you are likely aware, is the most severe form of the hypertensive disorders of pregnancy, which are on a spectrum. Mortality and morbidity within the hypertensive disorders of pregnancy are largely related to preeclampsia and the other severe spectrums, which include eclampsia and HELLP. Although gestational hypertension and chronic hypertension within the less severe spectrum can still be associated with morbidity and mortality. As you will see here in the pathophysiology of preeclampsia, there are several factors that come into play, including genetic factors, immunological factors, and it relates to placentation. This abnormal placentation relates to uteroplacental mismatch, which then results in placental intrauterine growth restriction and can lead to the maternal syndrome, which you will see is highlighted at the bottom. And as you can see, several target end organ manifestations can occur, including involvement of the cardiorespiratory system, the central nervous system, kidneys, gastrointestinal, and hematologic. It is unclear how these maternal adverse conditions predict fetal or neonatal outcomes. Fetal manifestations can occur before, with, or in the absence of these maternal manifestations. In the next slide, you will see the fetal-placental implications of preeclampsia. This slide is from the Canadian guidelines on the hypertensive disorders of pregnancy, where there are two categories. There are adverse conditions, which listed here include non-reassuring fetal heart rate, intrauterine growth restriction, oligohydramnios, absent or reversed end diastolic flow. Adverse conditions can increase the risk of severe complications. And the severe complications related to preeclampsia that have fetal-placental implications include abruption, which, as you know, can have maternal or fetal compromise or both, reverse ductus venosus A wave, and stillbirth. The severe complications warrant delivery, and we will come back to this at a later slide. We will now move on to the next slide, which talks about the natural history of preeclampsia. Studies have shown, particularly two good randomized controlled trials, that expectant care of severe preeclampsia generally is associated with pregnancy prolongation of an average of 2 weeks. There is a 2009 systematic review that found similar, that if you put all the studies together and you have early severe preeclampsia before 34 weeks, with 39 cohorts and a large number of women, that we're able to prolong pregnancy by only 7 to 14 days. It would be natural to think that by doing expectant care, we might be able to improve perinatal outcomes. Interestingly enough, the systematic review found that a conservative approach actually can increase the risk of abruption and small for gestational age infants. Now, studies in the past have shown results in the opposite direction, but the systematic review actually shows that perhaps the prolongation doesn't actually result in better outcomes. We'll move to the next slide, which again goes back to the Canadian guidelines. And I just wanted to again highlight that when we are talking about a conservative approach or pregnancy complications, we do have to keep in mind that there are certain complications that warrant immediate delivery. And in that situation, a conservative approach would not obviously be advisable. And again, if you look at the top, those are all the maternal adverse or severe complications that warrant delivery. At the very bottom, this will be familiar to you from one of my previous slides, that there are 3 conditions related to perinatal or fetal outcomes that warrant immediate delivery. Next slide. When we look at preeclampsia and perinatal outcomes, there is, not surprisingly, a spectrum again. There is preterm birth associated with preeclampsia, and as you know, there are 2 types of preterm birth. There's spontaneous preterm birth and provider-initiated preterm birth. And the past few slides where we've talked about the severe complications that warrant delivery in maternal and perinatal, that would be a time that provider-initiated preterm births would come into play. Fetal outcomes tend to cluster around the diagnosis of preeclampsia, whether we define preeclampsia as traditionally as gestational hypertension and proteinuria, or more broadly as most guidelines now have done, which is to define preeclampsia as hypertension with end organ dysfunction. Other outcomes related to preeclampsia in the perinatal realm include IUGR, low birth weight, stillbirth, and neonatal death. In a secondary analysis of the WHO multi-country survey, hypertension actually showed a higher prevalence of not only provider-initiated preterm delivery, but also spontaneous preterm delivery. With respect to spontaneous preterm birth, preeclampsia was associated with an adjusted odds ratio of 1.25. With provider-initiated, the adjusted odds ratio were 8 times higher. And in the WHO multi-country survey, 3/4 of the preterm births were actually spontaneous preterm births. If we look at other studies, including a multi-center Brazilian study called IMIP, that showed that 33% of preterm births were associated with preeclampsia. And generally what we see from a systematic review from the WHO and corroborated by the IMIP study from Brazil, there is a recent upward trend both nationally and globally with respect to preterm birth rates. Next slide. I wanted to focus a bit on provider-initiated preterm birth. As I have said, it is not surprising that hypertension is a leading cause, if not the leading cause, of provider-initiated preterm delivery. In a study from Brazil, the spectrum of hypertensive disorders, not just preeclampsia, but chronic hypertension, gestational hypertension, and HELP, were all common indicators for provider-initiated preterm birth. As you see, preeclampsia had the bulk of it at 58%, and the odds ratio was 15 when it came to preeclampsia in that study. Similarly, the WHO multi-country survey also shows that in women who had provider-initiated preterm birth, pre-eclampsia was a major cause for it. Interestingly, what we find in the WHO multi-country survey is that 14% of provider-initiated preterm birth were not medically indicated. So it appears that the countries where the most preterm births occurred without a medical indication were actually Sri Lanka, China, and India. We do have to keep that in mind, that preeclampsia rates are also highest in both Africa and Asia, and whether that links in is difficult to say. Now, the study doesn't explore further as to what the indications were or what made the providers deliver, or in fact, what actually did they mean by medically indicated. So I don't have any further comments on it, but this certainly would be an area to explore. In the IMIP study, they found similar results where only about a quarter of provider-initiated preterm births were due to maternal conditions that were supported by exams or tests that then would highlight the importance of making evidence-based decisions. And the final comment on this slide is that in the IMIP study, they found that regardless of gestational age, the hypertensive disorders of pregnancy were the leading cause of provider-initiated preterm birth. We'll move to the next slide. When we look at the geography of preeclampsia-related preterm birth, as I mentioned, preeclampsia rates tend to be highest in sub-Saharan Africa and South Asia. That's also where we see the most preterm births, but it's also the region where there are the most live births, just by the nature of the. Okay, so we'll try this again. The proportion of preterm births that were provided when we look at this particular study, and this was again done by the group at WHO, where they looked at, they categorized countries by the Human Development Index. And what they find here is that hypertensive disorders were associated with both spontaneous and preterm births in all Human Development Index group countries. So regardless of whether this was a very high HDI, high, medium, or low, all across the board globally, hypertensive disorders were associated with higher spontaneous and provider-initiated preterm birth. Now, one interesting point here, and it may not be entirely surprising, is that the proportion of preterm births that were provider-initiated actually increased as the Human Development Index increased, with the percentage being 20% in low HDI countries and 40% in high HDI countries. We could argue or hypothesize that in higher HDI countries, because of the resources available, perhaps providers tended to be quicker at initiating birth. Now, whether they're entirely evidence-based remains to be seen, but it is an interesting point that the rate of provider-initiated preterm birth actually increased with the higher Human Development Index countries. The other comment that, again, I wanted to go back to highlight that it's not just preeclampsia, but the spectrum of hypertensive disorders of pregnancy that are important, is that chronic hypertension, and both chronic hypertension and preeclampsia had a similar impact on preterm birth rate in all 4 Human Development Index subgroups. Chronic hypertension was associated with an adjusted odds ratio of 2.28 for preterm birth, whereas preeclampsia and eclampsia had an adjusted odds ratio of 5.03. We'll move on to the next slide. When we look at preeclampsia and perinatal death, not surprisingly, the estimates vary, but between 9 to 20% of perinatal deaths are reported to be a direct result of the hypertensive disorders of pregnancy. And this has been seen in several large multi-country cohort studies. For example, if we look at the nationwide inpatient sample study of all deliveries in the US, 7.5% of all stillbirths were due to preeclampsia. In the Norwegian Medical Birth Registry, the relative risk of fetal death among women with preeclampsia was quite high at 26 weeks, as high as 86, but 7.3 at 34 weeks and 3.0 at 38 weeks. So the earlier and more severe the preeclampsia, I think, again, not surprisingly, the higher the risk of stillbirth and other adverse perinatal outcomes. The risk of stillbirth and early neonatal death is lower in spontaneous preterm deliveries compared with provider-initiated deliveries. And it goes back to our hypothesis that we wonder if all of the provider-initiated deliveries are indeed medically indicated, and if they are, and if the timing is indeed correct. Because as you saw, the earlier that the preterm birth rate is, the higher the risk of stillbirth and other complications. We'll move on to the next slide. So before I end, I wanted to again highlight the importance of recognizing chronic hypertension. We focus a lot of our discussion on preeclampsia because we know that the outcomes tend to be severe. But as we see countries going through obstetric transition where we're moving away from direct causes of death to indirect causes of death, pre-existing medical conditions come into play, and chronic hypertension is a key condition. The prevalence of chronic hypertension in pregnant women, unfortunately, is unknown. The estimates are old and not based on high-quality studies. There is a systematic review being conducted by the WHO Maternal Morbidity Working Group, which is currently underway, and should be able to give us a better estimate of chronic hypertension. These studies are usually not population-based, and most are from high-income countries, which skews the estimates. This slide is from a systematic review that was done looking at the adverse perinatal outcomes in women with chronic hypertension. This study included 55, or the systematic review included 55 studies with a total of 800,000 women. And as you can see, that the risk here with chronic hypertension with respect to preterm delivery is estimated at about 28%. Going back to the IMIP study from Brazil that I talked about, it showed a 5-fold increase in preterm delivery with chronic hypertension. The Brazilian study IMIP also found that not only just chronic hypertension, but other maternal morbidities such as diabetes, cardiac disease, lupus, also showed a higher risk of provider-initiated preterm birth. So as countries go through obstetric transition, we need to keep in mind that pre-existing medical conditions, and often women will have more than one, are going to increase that risk of preterm delivery and also increase the risk of superimposed preeclampsia. So we have to be aware of these changing demographics. We'll move on to the next slide. So in summary, as you can see, that preeclampsia is associated with a number of adverse perinatal outcomes, and that it is associated with both spontaneous and provider-initiated preterm birth. But it is not just preeclampsia, but we need to consider the spectrum of hypertensive disorders of pregnancy, particularly chronic hypertension, when thinking about perinatal outcomes such as preterm birth, low birth weight, and neonatal mortality. We'll move on to my final slide, where I just want to briefly highlight some of the gaps. So as we've seen, there are regional variations with respect to preeclampsia prevalence and the rates of provider-initiated preterm delivery, and we need better quality studies to truly understand the true prevalence of both of these. There needs to be more exploration around provider-initiated preterm delivery, particularly what were the reasons for delivery? Were they indeed medically indicated? Were they evidence-based? And what was the timing of delivery? We need to also focus on the management of some of the modifiable factors that may occur with the hypertensive disorders of pregnancy, and severe hypertension is one of them. We can treat severe hypertension and prevent morbidity. So the optimal and timely management of severe hypertension needs to be discussed. Studies show that there is a lack of provider knowledge around the management of severe hypertension. So that is why I highlight this. I know I've talked a lot about chronic hypertension, but my point here is that perhaps preconception counseling would be key here so that women who have chronic hypertension are seen before pregnancy and surveillance is instituted so that morbidities or complications are picked up earlier. Which brings me to the point around preeclampsia risk modification and surveillance. And finally, guidelines and protocols, the need for standardization so that there's uniformity in indications for delivery. So I will end here, and I believe we have a few moments for questions if there are any.
Thanks to Bassem for your presentation. So far, we don't have any questions for you. Moving forward to our next presenter is Jannica Hartvig-Blomberg. She is a senior manager of the Maternal, Infant, and Young Child Nutrition Global Program at the Global Alliance for Improved Nutrition, which she joined after 4 years as a nutrition specialist with the World Bank's Africa region, where she supported the health, social protection, and agriculture sectors.
Thank you, Amy. Next, please. When we speak of suboptimal nutritional status or malnutrition, we refer actually both to over and undernutrition, even though most people are most familiar with the term being associated solely with undernutrition, but it actually refers to both. So it's both obesity and underweight, as well as stunting and micronutrient deficiencies. And the malnutrition of pregnant women or even women of reproductive age prior to pregnancy can negatively influence both a child in utero as well as a child later in life, both sort of in the initial few years, but even the nutritional status of her child in adulthood, which then in turn can also influence her children to come, so hence the woman's grandchildren. This is what we will call the intergenerational effect of poor nutrition. Next, please. So as mentioned, so the suboptimal maternal nutritional status can be caused by a range of different issues. So you will see here these nutritional problems can vary from again, overweight to obesity and micronutrient deficiencies. And these, in turn, can have a whole range of consequences that differ, consequences both on the child and the woman herself. Next. There are some short-term consequences, but there's even long-term consequences, such as, for instance, increased risk of obesity or cardiovascular disease of a child in adulthood. Thanks. Next, please. If we look at, for instance, the causes of maternal deaths associated with also the nutritional problems associated with these causes of maternal deaths, we can see again that it's, and this is just illustrative, it's not exhaustive list, but we can see that there's again a range of poor nutritional statuses, so different nutritional problems that are associated with different causes of maternal deaths. Next, please. And today we'll look at sort of the risk factors for the hypertensive disorders and the preeclampsia. It's just important that we keep in mind that the relationships between sort of a single nutritional problem and a health outcome is more complex, and that it has a nutritional problems such as, in this case, for instance, vitamin D deficiency, can actually have impact on more than one health outcome. Next, please. If we look at the nutritional risk factors for preeclampsia, then one we cannot ignore is maternal weight. We know that an overweight woman has about twice the risk compared to a normal weight woman of preeclampsia. And this relationship actually continues to double as she gets more and more obese. Hence, a more obese woman is actually at a fourfold increased risk of preeclampsia than that compared to a normal woman. The new micronutrient status of pregnant women also have been found to be associated with an increased risk of preeclampsia. For instance, supplementation trials with multiple micronutrient powders or multiple micronutrient supplements has been found to have an associated decreased risk. It's even more clearly in trials with calcium supplements. While the effect size varies based on baseline calcium levels of individual women, a meta-review of almost 1,600 randomized control trials have found that calcium supplementation is associated with a decreased risk of 52%. And just to mention, sorry, that this effect is actually even higher in women who are already at risk of preeclampsia, such as if they've suffered from preeclampsia before, if they have diabetes, chronic hypertension, renal diseases, autoimmune diseases, etc., like we heard of before. And for these women, calcium supplementation might even reduce the risk of preeclampsia as much as 78%. So studies have also found an association between vitamin D deficiency and an increased risk of severe preeclampsia, especially if the deficiency happened early in pregnancy. Next, please. So what preventative interventions do we have evidence for? Well, if we're looking at the WHO recommendations for the prevention and treatment of preeclampsia and eclampsia, and we see that we have strong evidence for calcium supplementation. But we need to be mindful again, and this is also clearly stated, that since the effect really is based on a woman's existing calcium status, and since this is difficult to determine or complex to determine, then the recommendation for calcium supplementation as a preventative intervention is only for populations with known calcium levels that are low. So basically, the aim here is for calcium supplements to fill a dietary gap and that way have an impact on risk of preeclampsia, not by working as a therapeutic agent. Next, please. So with respect to some of the other evidence, we have multivitamin supplementation, physical activity. Well, we do have some studies that show an association between multivitamin supplementation during pregnancy as well as preconception physical activity. Then these are not recommendations that are included in the WHO guideline. But generally speaking, the recommendation here is to improve instead the nutritional status, including through both sort of the optimizing of body weight, but also in terms of sort of the general nutritional status and good dietary practices of women. And actually there is no evidence for the reduction of salt intake for pregnant women. And I apologize for the lack of clarity in my slide. I'll make sure that the slide that gets uploaded is more clear on that. The WHO recommendations highlight that there is currently insufficient evidence for the vitamin D supplementation, but there's probably good chances that this is going to be changed in the future, since there's ongoing studies happening right now. So this may change in the future. But again, we just have to keep in mind that in any case, a given nutritional problem is associated with a range of outcomes, and whether or not we have evidence for that particular intervention for its risk of preeclampsia or for its preventative effect on its own might not be sufficient to warrant its use, then it still might be an intervention that has impact on other health outcomes and hence might still want to be pursued. Next, please. Oh, sorry, there was just to say there's no impact, thanks, of antioxidants. So next, please. If we look at sort of the nutritional determinants of low birth weight here, we can see, next, please. Sorry, I have some circles. Oh, and the circles have moved. Apologies, I have my presentation in a slightly different form, and this is what's happening. So the circle here was really supposed to be slightly higher on hypertension, vitamin D, calcium, when we talk about small for gestational age. But basically, the point here that I'm trying to make is that certain nutritional problems have its impact on other outcomes, either directly or indirectly. So, for instance, overweight, which we know is a risk factor for preeclampsia, also is a risk factor for preterm through its risk of preeclampsia, and similarly is vitamin D. But next, please. Vitamin D deficiency, and again, that is also in the wrong place, but that in itself is actually also an independent risk factor for, in this case, for instance, small for gestational age. Third, next, please. We also need to be mindful that we have issues both with respect to overweight and underweight. So while we are definitely not wanting a woman to be overweight or obese with respect to risk of preeclampsia, we also need to keep in mind that if she becomes too thin, if she goes, we push her too much the other way, if she's underweight, that can again put her at increased risk for having a child that is small for gestational age. So it's again about keeping in mind that we cannot look at a given nutritional risk or problem and its outcome in terms of preeclampsia in and of itself, because it's a risk factor potentially also for other poor health outcomes. Next, please. So what is it that we want? Well, we really need to then optimize the weight of pregnant women even prior to pregnancy, and this includes the promotion of physical activity, but also includes general healthy nutrition, etc. And then we want to promote healthy nutrition during pregnancy, and this can be done through various of means in terms of general promotion of good dietary practices, through specific interventions to improve micronutrient intake, such as you heard here with supplementation of calcium, although that can also be done through other means. For instance, you can actually use fortification and other interventions instead. And then there are some interventions that you don't want to target specifically for pregnant women, but you want to target a whole population for. It's not one that, in the case of reduction of salt, one that is effective intervention for just the prevention of preeclampsia for pregnant women, but one that you would want the whole population to benefit from due to its associations with increased risk of hypertension in general. Next, please. So basically we have sort of more the immediate factors that we need to address in terms of the healthy diet, physical activity, micronutrient supplementation, etc., both prior to and during pregnancy. But also we need to keep in mind that there are more sort of intermediary factors that need to be addressed. For instance, there are challenges with food nutritional security that, by the way, also is not just a question, a problem in developing countries, but also is a challenge in more developed countries such as the UK or Ireland, France, US, Canada. They all have evidence that especially the poor have challenges in accessing with the more nutritious foods or food products, for instance, by a lack of shops in their near vicinity that sells more nutritious foods, and instead sort of an overload of your chicken and chips and your convenience shops, etc. Next slide, please. Lastly, we need to ensure that we reach and target women prior to pregnancy. This is because a lot of pregnant women don't plan their pregnancies, and it also means targeting adolescent girls since they contribute to a large number of pregnancies worldwide. It's about 1/10 of all pregnancy worldwide. Secondly, we also need to intervene beyond the health system. Next, please. This is not just because women often don't interact with the health service or health services in the health system unless they're pregnant or critically ill, but also because some of the risk factors, in this case risk factors associated with increased risk of preeclampsia, such as overweight and obesity, they require interventions and support that go over and beyond of what the health system can offer. I guess if we all think about challenges with losing weight, we can recognize that maybe having a 5 or even 15 or 20-minute session with your doctor is not the only thing that is going to support you to lose that weight. There are many other things that are needed to support you for that. Next, please. Last point. So that we don't forget, it means that not just do we need to target sort of women prior to they get pregnant, we also need to intervene sort of in their entire environment, not just through the health system, and we also need to work on changes of the overall society, for instance in terms of eating behaviors, etc., and not just target individual behavior change. Thank you. That's all I have for now. Next. Oh yeah, that's just some references for those who are interested. Next, please, and then I have my thank you slide.
Okay, so we did just have a question for Jannica. The question is, what is the best approach for calcium supplementation?
And here I presume that we are talking about for women in like calcium deplete areas, correct? Because basically, so the point here is that calcium supplementation is not recommended for populations where there isn't a calcium depletion, and otherwise there is specific guidelines in terms of the dietary calcium recommendations. It usually it differs from country to country based on baseline values, but it's usually about 1 gram per day. It's usually it's much higher than many of the other micronutrients, and then there's recommendations in terms of how it should be taken because there are some interactions between calcium uptake and that of iron. So you don't want to be asking the woman to take it at the same time as she's taking her iron tablet, which is something that pregnant women are generally always taking, or most countries that I'm aware of, they have the recommendation of or developing countries of the 90+ days of iron supplementation. So you would want them to consume it a few hours different than that of the iron tablet. So I don't know if that answers the question. Basically, it depends. It's country specific, based also on how much sort of they get through their dietary intake. So what you're trying to again reach is or cover is that gap from the dietary intake to what is the optimal sort of amount that's being considered, and that recommendation is slightly different from country to country.
Okay, so that is it for our presentations. We want to thank everyone for bearing with us through all of our technical issues. We're a new project with an even newer website, and this is our first webinar, so next time around we will have all of those kinks sorted out. Also, just as a follow-up, if there are any questions that you have, we would like to defer you to our website, to the discussion forums. On the top right side, there is a community tab, and if you scroll down to the discussion forum, it sends you to an online community of practice that is specific to preeclampsia and eclampsia. Lastly, as a follow-up, we will email out all of the slides to anyone who registered for this webinar, as well as post them on our website under the webinars tab, which again is under the community tab on the right side of our website. So thanks again for taking the time out of your busy schedules to tune into our webinar, and we look forward to the next one.